Good morning, everyone. Adjust your expectation a little lower. I'm asked to talk about beta blockers in patients with advanced cirrhosis and ascites, and my job is to keep you entertained and occupied for the next 45 minutes. So I'll do my best. I'm going to take a case through the talk and make things somewhat relevant to your practice. So this is a 59-year-old man with abnormal liver enzymes, history of hypertension, borderline diabetes, some alcohol use, two beers 3-4 times a week. BMI was 33, truncal obesity, palpable liver edge. Ultrasonography showed nodular surface of the liver, no mass, small amount of sliver of fluid. Spleen diameter seemed to okay, maybe upper limit of normal. Liver function tests were by and large normal. We did elastography, came back 18 kilopascal, which is in cirrhotic range. People familiar with, right? Okay. So that's the data. I split that was 165,000. What is the most appropriate action in this gentleman who seemed to have cirrhosis at this point, but doing well? Number one, perform an upper endoscopy and ligate varices to eradicate. Who says number one? Any enthusiastic endoscopists? Initiate surveillance for hepatocellular carcinoma. Is it risk? Yes, more hands. Carvedilol, 3.125. Furosemide, no need. How about lactulose? Yeah. Okay. So my answer is number two, and the reason why number one is not the right answer is this is a current ASL guideline. At the bottom it says you don't need to do an EGD if liver stiffness is less than 20 and platelet count is over 150, because there's a very low probability of high-risk varices in that situation. So this patient, according to the ASLD guideline, is somewhere between compensated cirrhosis with no portal hypertension versus a little bit of portal hypertension. Here, the portal hypertension is defined as 10 millimeter in mercury. So this is the sort of the scheme for compensated cirrhosis. The goals of treatment in patients with compensated cirrhosis is to try to prevent them from going to the next stage. So the topic today is non-selective beta blocker in cirrhosis. And this is a little bit confusing. And if I'm going too basic, you can tell me so later. So there are two kinds of beta adrenergic receptors. Beta 1 is in the heart. Beta 2 are in the peripheral blood vessels. When you block it in the heart, beta 1 blockade reduces heart work. So it reduces heart rate, it reduces blood pressure. Beta 2 blockade leads to splanchnic vasoconstriction. So it kind of works in an opposite way. So if you combine beta 1 and beta 2 blockade, the heart works less to push blood through the splanchnic system or to the liver, and the splanchnic blood vessels are constricted, so there's less blood flow going through the portal system. And when you have a lower flow, the pressure goes down. That's how a combined beta 1 beta blockade reduces portal pressure. So that is true of propranolol and nadolol. Carvedilol is sort of a new kid on the block in the liver world. It's been around for years, but for the liver, people realize that there's an additional component to carvedilol, which is alpha-1 adrenergic blockade, which decreases the portal venous resistance. So whatever flow comes into the portal system, blood vessel relaxes, and that further reduces the portal pressure. But the hitch is that because it's an alpha adrenergic blockade, it reduces blood pressure as well, systematically. So that becomes a bit of a complication. Just to remind you, the correct doses of beta blockers, propranolol, nadolol, and carvedilol. Carvedilol I'll come back to because we're not too familiar with that drug perhaps. But usually propranolol and nadolol, we start 20/40. BID for propranolol and 20 to 40 nadolol. According to the guideline, the maximum dose is quite high. And I've not seen many liver patients taking 160 milligrams of nadolol and so forth. Most of the time, we just settle out around 40 or 80. So keep that in mind. And also, you need to monitor the patient because beta blockers reduces heart rate and blood pressure. And as you know, many of our patients already have pretty low blood pressure. That's a point I will come back later. So this is a little bit of a repetition. The guideline, no to mild portal hypertension. We want to prevent development of clinically significant portal hypertension or decompensation. And the big point here is think about treating the underlying liver disease. If you're dealing with hepatitis C, hepatitis B, it's easy. You need to treat those viruses and make the cirrhosis try to regress or lessen. However, in this situation, using non-selective beta blocker in the absence of significant portal hypertension is not justified because for beta blockers to work, there needs to be abnormal circulation in the portal system, and that has not been developed in this situation. Patients with clinically significant portal hypertension greater than 10, then there may be a role for non-selective beta blocker that I will talk about next. So this is an old study, a little bit of old study, where people try to prevent varices from developing in patients without varices and cirrhosis by using timolol, which is a non-selective beta blocker, and did a randomized control trial. Obviously came out in New England Journal of Medicine, important paper, but the study was negative. So using non-selective beta blocker in people without varices, they failed to demonstrate that you cannot prevent varices from forming. Okay, so that was sort of the gold standard. Just this year, there was another big paper that came out in Lancet, where they used non-selective beta blocker to prevent hepatic decompensation in patients with compensated liver disease. So this was a Spanish multi-center placebo-controlled trial, and the endpoint there was not prevention of varices, but prevention of decompensation and death. Here, the decompensation definition was standard: ascites, portal hypertensive GI bleeding, or overt hepatic encephalopathy. As you see in the graph, patients who received beta blocker had much lower incidence of the primary endpoint, death or decompensation, has a ratio of basically 50%. You can reduce the risk by 50%. So that is significant and potentially practice changing. So I'd like to delve into a little bit more detail of this paper. So these were compensated cirrhotic patients. Everybody underwent hepatic venous pressure gradient measurement and found to have greater than 10 millimeters in mercury. So that is a bit of a thing that we don't do, and how we apply this data is something that we need to think about. Patients did not have varices or only small varices with low risk of bleeding. And patients who are sick with high bilirubin, low platelets, and so forth were excluded. The unique thing that they did was they took the patients to the lab and did the HVPG measurement. As you can see in the second box, they gave propranolol IV and saw how much their portal pressure went down acutely in the lab. And then they factor that into their randomization. If people responded to acute propranolol, they were assigned to receive propranolol PO. If they did not respond to propranolol in the lab, they were given carvedilol, okay? And then they were randomized to get the beta blockers or placebo, and that's the result that we're seeing. This is a subgroup analysis, and Child-Pugh score didn't matter very much, but patients who had small varices as opposed to no varices had more benefit. And patients who had alcoholic cirrhosis didn't seem to have benefit, but as you heard, non-alcoholic fatty liver disease, which is an important cause of cirrhosis, those seem to be the patients that benefit from this approach. So, oftentimes we see these patients with fatty liver disease that we have and cirrhosis, and we have very little to offer. We just keep our fingers crossed that somehow some weight loss will stop their disease progression and so forth. This is something that we can think about. Primary endpoint in responders, propranolol was 19% compared to placebo's 26%. Here you see the median dose was 80 milligrams. In people who did not respond, who were given carvedilol, the response seemed to be more dramatic. So in patients who received propranolol, 19% instance of bad things. Carvedilol was 9%, even lower. So this kind of works to our advantage, where we don't do the HVPG and IV propranolol challenge to see if it responds or not. Everybody can go on the carvedilol arm and expect some benefit from using that. So that's new piece of data that I think is important. So far, we talked about compensated liver disease with no portal hypertension. There's no role for non-selective beta blocker. Again, know the numbers, stiffness less than 20, platelets 150, no EGD is needed. In patients with compensated significant portal hypertension with no or low risk varices, consider carvedilol to prevent hepatic decompensation. What do you mean by variceal bleeding risk? And there are three things. One is liver function, the second is red signs, and the third is size of the varices. If you have large varices, if you see a red whale sign, red signs on the varices, or if you have CTP class C patient, those are the high-risk patients that we need to think about preventing variceal bleeding. Old papers, I'm going to show you to give you some appreciation where this whole thing came from. So this is 1987 New England Journal of Medicine, French multicenter study, where they used propranolol to prevent first bleeding in patients who they thought were at high risk of variceal bleeding. So these are the numbers. There were patients who had Child-Pugh score A and B and C separately. They were randomized to receive placebo and propranolol. You can see that there were various degree of large varices, mostly alcoholic liver disease. Liver disease was mildly decompensated, but normal kidney function. I think that's something to think about. And then look at the average the daily dose of propranolol, 160 milligrams. That's a large amount that we rarely use. With that, the percent of bleeding patients, you can see in the upper left, upper right figure, there was a hazard ratio of 0.7, 30% reduction of bleeding with the propranolol, and a hazard ratio of 0.96, 4% reduction in survival. I'm not sure about the statistics. This doesn't make sense that you can have so small hazard ratio and highly significant p-values, but that's what the paper said. So 30% reduction with pretty high doses of propranolol. With that, you can reduce the risk of variceal bleeding by about 30%. The next study, the very next year, this was another French study using nadolol. And I won't go into the details, but look at the figures. The intent to treat analysis, if you compare nadolol versus propranolol and ending nadolol P, P is a placebo, not propranolol. The difference between those two curves is not as impressive as the propranolol figure. And I don't think that's a difference between nadolol versus propranolol. It is just that if you do a lot of experiments, there's a variation, and just gives us an appreciation of the magnitude of difference that you would see. If you look at the per protocol, that seems to reproduce the propranolol experience. And the difference between the two is obviously people who cannot tolerate nadolol or beta blockers in general. So again, another dimension into this data is that patients who take the beta blockers and can tolerate it at high doses get about 30% reduction in the risk of first bleeding. This is a recent paper that looked at what's the right amount for carvedilol, that's sort of a new kid in block. And here the endpoint was HVPG portal pressure reduction of greater than 20%. That was their gold standard. So the way they did it is to challenge people with carvedilol 6.25 and see how many people responded in terms of HVPG. You can see the darker green bar, about 40% responded to 6.25. And then patients who did not respond to that degree were elevated, escalated to 12.5. And then there was additional about 30% of the group. So overall, about 50-some% of the patients responded at level of carvedilol of 12.5 milligrams. So those are it's an odd number, it's hard to remember, but 6.25 is the initial dose. In patients who don't seem to respond, 12.5 is where you stop. Important thing here is the changes in pulse rate or arterial blood pressure did not predict portal pressure response to carvedilol. So for many of us who don't perform HVPG often, beta blocker use is frankly a bit challenging. Patients with ascites had less hemodynamic benefit and poorer tolerance to carvedilol. We come back to that point later on. This is an abstract that was just presented at the liver meeting where they compared carvedilol, endoscopic variceal ligation, or combination of both in tau BC cirrhosis. So the figure is a little bit small. The incidence of bleeding was highest in patients who just received carvedilol, that's the blue line. Patients who had variceal ligation, the green line, had lower risk of bleeding, and patients who received both was the lowest. This is a controversial data that I don't want you to go home and do this, because the AASLD guideline says there is only one paper that compared this in a fully published form, and they failed to demonstrate the combination of beta blocker and variceal ligation is more helpful than either alone. So the current guideline at this point in patients with compensated liver disease or mildly decompensated liver disease with high-risk varices who have not bled, prevention of their first bleeding is beta blocker or variceal ligation, and highly doubtful combination to prevent bleeding. Beware of underdosing. The studies were done with very high level, in my opinion, high doses of beta blockers, and many of those European studies utilized portal pressure measurement as their treatment guide. So in my simplistic GI point of view, if you don't have varices, you can't bleed from variceal bleeding. So I tend to use variceal ligation liberally, and in patients in whom that is not appropriate, you can use beta blockers, but make sure that you use the right amount. Yes? Yes. Yes, I'm going to come back to that, but thank you. I wholeheartedly agree with you. So the question was how you deal with hypotensive patients or people who don't have robust blood pressure. How much do you need to struggle to keep them on beta blockers? I'll come back to that point. So this patient was lost to follow-up, and then he came back 2 years later with hematemesis, 3 trunks of large distal esophageal varices with red signs. Ligation was performed. He had decent blood pressure with a mean arterial pressure of 88, pulse of 82, classical signs of chronic liver disease, ultrasound. Now he has ascites. His liver function is mildly decompensated. Creatinine was still normal. In this setting, patients who just have bled, the following medical therapy is planned or instituted, which has shown to improve survival. Does ligation of varices to eradication improve survival? Carvedilol. Spironolactone, probably not. How about liver transplant? All of the above. Any liberalists? Okay. So the right answer is liver transplant. It's sort of a party line in patients who have initial decompensation, very severe bleeding, always think about liver transplant. In this day and age, when organs are not very scarce, there may be a small window of opportunity that we can help these patients. So this table completes the AASLD guideline. Compensated on the left side, we already talked about. Decompensated patients usually have high portal pressure, greater than 12. Varices are usually present. Acute variceal bleeding, we control the bleeding and prevent early rebleeding and death, which I'm going to talk about in the next section. Again, patients who are sicker with complications or without complications, reducing mortality and thinking about liver transplant in the right timing would be something to think about. So in patients who have compensated or mildly decompensated with bleeding history, the right approach is to use beta blocker and variceal ligation together. And this is because they have been shown to be better than monotherapy alone to prevent rebleeding. So this is a guideline level knowledge. I'm not going to go into that any further. So the patient was treated appropriately. However, over time, he develops increasing ascites and peripheral edema. Now the patient returns to the clinic feeling unwell with mild temperature. His medication is moderate to high doses of diuretics, Nadolol 80 milligrams pushing. Now his blood pressure is low, 98/65, large ascites, small umbilical hernia. Now his liver function is more grossly perturbed with total bilirubin of 2.5, low albumin, creatinine is elevated at 2.1, sodium of 128. Now, we did a paracentesis. He has PMN of 430, indicating that he has spontaneous bacterial peritonitis. So he's become quite ill at this point. So what do you do with beta blocker in this setting? Who thinks that beta blocker may be responsible for his AKI? Yes? Will beta blocker in this setting improve survival? How about improving cardiac function? We use beta blockers in AMI patients. Should be continued regardless of systemic blood pressure? Not all of the above. So number one is the right answer in my mind. I'll give you some data about that. So this was a review by Florence Wong that talked about the advantages and disadvantages of using beta blockers in patients with advanced cirrhosis. The positive aspect of beta blocker is, as we just discussed, it will reduce portal pressure and reduce the risk of variceal bleeding. That's number one. Emerging data shows that beta blockers can potentially reduce bacterial translocation. We didn't talk too much about that, but cirrhotic patients have leaky gut and bacteria get into the portal system, and the endotoxin and other things screw up further what's going on in the liver disease, in the liver. And there's theoretical benefit of using beta blocker to reduce the risk of spontaneous bacterial peritonitis. But on the left side, the downside of using beta blocker, it reduces cardiac output. And in patients who have advanced liver disease with high risk of renal insufficiency, that could be detrimental for their renal perfusion, and then that leads to hepatorenal syndrome. So it becomes a difficult balancing act in patients with advanced cirrhosis, how to use beta blocker. So there's a window theory where beta blocker may be placed in the spectrum of cirrhosis. At the beginning, patients who have a low portal pressure here at the, here at the beginning, the portal pressure is low. There are no varices, there are no ascites. Renal perfusion is good. And then as a patient progresses, portal pressure goes up. You may have varices, ascites may be forming, and renal perfusion becomes gradually lower. And in the end stage, portal pressure is high. People have varices and refractory ascites or SBP by the time the renal perfusion is at a low level. So in the early part of the course, beta blocker has no role because there's no benefit. There's nothing to gain by putting patients on beta blockers there. In the far advanced stage, there are many things that could go wrong with beta blockers that I will talk about in the next few slides. So be careful in patients with advanced liver disease. It is a sweet spot in the middle when the patient is doing fairly well, compensated liver disease, the blood pressure is decent, they may have varices where there's a benefit of very severe bleeding, ascites is no to mild. That's the window where beta blockers will have the most bang for the buck. So the downside of beta blockers was first suggested when they talked about paracentesis-induced circulatory dysfunction. These are patients with large volume ascites. You tap the patient and it goes, their circulatory system goes haywire because they become acutely volume depleted as a result of ascites drainage. So they did an experiment in a small number of patients who are on propranolol. They did a tap and measured their plasma renin level, which is a marker of circulatory dysfunction. On propranolol, 8 out of 10 patients had circulatory dysfunction. When they took those patients off propranolol, repeated experiment, then the circulatory dysfunction went away. So beta blocker messes with the patient's ability to compensate for fluid shift and manage renal perfusion in a physiologic way. This is the first paper that showed that beta blockers could be harmful. And this particular patient was the same patient group as the previous slide, refractory ascites that require large volume paracentesis. If you look at the survival curve, there's a significant difference between patients who continue to take beta blockers versus who did not. So using, in this patient population, can be using non-selective beta blocker can be dangerous. But if you compare the two groups, they are not similar. So patients who were taking non-selective beta blocker in this patient group was sicker and had more Child-Pugh score and so forth. So this difference may not be attributable to beta blocker per se. These were just sicker patients who happened to be taking beta blocker. So the data here is not that clear. There have been a plethora of papers that came out addressing these same topic. And the meta-analysis that looked at non-selective beta blocker in cirrhotic patients with ascites, the summary hazard ratio is 1. So when you, so that's the point. Yes, so I'll come back to the point. So no, it's okay. So in the meta-analysis setting, it is very difficult to really define what kind of ascites it is. So this is patients with all ascites. They put together some papers with refractory ascites, some papers just ascites. So it's difficult to tease out. So in this meta-analysis, they failed to show that there is survival disadvantage associated with non-selective beta blocker. So if you look at the dots, they're all over the place. Some favor being on beta blocker, others favor not being on beta blocker. The third arrow is Cirrhosis. That's the paper that we just reviewed, that beta blocker may be dangerous. There are 2 other papers with substantive patient numbers, so I'm going to look at those papers. So the first Lighthead paper said beta blocker is a good thing. So this is a paper, a UK single center retrospective cohort of transplant candidates with ascites, all ascites. And there was no uniform protocol beta blocker administration. If you compare the 2 groups, they look similar. And their bottom line, when they looked at death, patients who were not taking beta blocker had worse survival, and beta blocker patients did better. But the paper also looked at transplant. So if you look at transplant, patients who are taking beta blockers were transplanted more than patients who are not taking beta blocker. So is this a chicken or egg? Is patients not dying because they were transplanted more, or did they stuck around to be able to be transplanted, they got transplanted more? It's very difficult to tell. So this is I'm just pointing out the limitation of the retrospective studies. It's very hard to tell what's going on with these studies. The third study deals with patients with spontaneous bacterial peritonitis. So along the same spectrum as refractory ascites patients who have far advanced liver disease. They looked at all patients that they tapped, and patients were moderately decompensated there. 30% had SPP, 40% of their cohort had beta blockers. They found that patients who are taking beta blockers were at a higher risk of hepatorenal syndrome or AKI. And as you know, both issues in patients with advanced liver disease is not a good thing for patients to have, directly related to mortality. So this particular paper suggests that beta blocker is not a good thing because it induces hepatorenal syndrome or AKI if you have spontaneous bacterial peritonitis. The same paper looked at survival. And this is also very interesting. If you look at the right panel, patients who had spontaneous bacterial peritonitis, people who were not taking beta blockers did better. Here, 60% better. That in patients who did not have SPP, beta blocker was a bad thing. But if you look at the left panel, patients who did not have SPP, earlier stage, perhaps ascites, then beta blocker was advantageous. So there is an interaction going on in patients with far advanced ascites, SPP, refractory ascites. Beta blocker is not a good thing. But in some patients who are not as advanced, beta blocker may be a good thing. So if you combine all this data together and look at it as a group, then it's very hard to tell what's going on. So this is a humble study that I did when I was at Mayo. We looked at our same retrospective limitations. We had large number of liver transplant waiting list patients. And the endpoint that we looked at was AKI or renal failure. And what we found was similar to what Mandorf or the other paper showed, that patients who had ascites, this is all ascites, ascites were taking non-selective beta blocker, that's the top curve. They had the highest instance of AKI. The lowest instance of AKI were patients who didn't have ascites, but were taking beta blockers. So to make the long story short, what happened was in patients who did not have ascites, taking beta blocker was a good thing, minimizing their risk of AKI. But in patients with ascites, beta blocker was detrimental in terms of renal failure. So there's complex intersection between beta blocker and what the patient is in terms of their stage of disease. Another piece of data that is just being published is with regard to cardiac dysfunction. So this was same patient population, waitlist registrants undergoing right heart catheterization, relatively large number of patients. If you look at the figure, in both groups, patients taking beta blocker, not beta blocker, as the MEL goes up, the curve goes go down. And the y-axis is a global cardiac performance metric called left ventricular systolic work index. So in both groups, advanced liver disease had bad impact on the cardiac function. But being on beta blocker accelerated that process, shifting the curve to the left or downward. So if you think about the cardiac function, that's what beta blocker does. It reduces the cardiac work. But what they found in the table, the very bottom line, is that there is an interaction, again, in patients who are taking beta blocker, it's okay. If they had some decrease in cardiac function, that's okay. But if you have a patient with reduced cardiac function from advanced liver disease and put them on the beta blocker, whatever kind it is, then that's when things bottom out and the patients have increased mortality. So it makes sense, right? So it's hard to make a uniform statement of how to use beta blockers in an advanced patients. if there's a advanced liver disease and that there are other complications, refractory ascites, SBP, and decreased cardiac function. If the patient is struggling with systolic blood pressure of 95, that's when you stop beta blockers. So compensated, we talked about this, compensated patients, we do nothing with regard to beta blockers. Carvedilol may be helpful in non-alcoholic fatty liver disease, small varices, it may prevent decompensation. To prevent first bleeding, beta blocker or ligation, in patients who have bled, you need to do both, beta blocker and variceal ligation to prevent rebleeding. And in patients with advanced liver disease with refractory ascites, SBP, or cardiac dysfunction, discontinue non-selective beta blocker in sick end-stage liver patients. And in those patients, you do need to protect them from bleeding by doing band ligation. So don't forget that aspect. Am I doing the time? Do I have a few minutes or am I done? Okay. There were a few abstracts that I'd like to share with you in case I'm totally boring you with beta blockers. There are a few nuggets that I'd like you to take home. Terlipressin, as you probably know, is a gold standard to treat hepatorenal syndrome in the world except Canada and the US. And they tried to show that this is a good thing in the US previous 2 times and they failed. This is their 3rd trial and it worked, okay? So hepatorenal syndrome type 1, patients who have creatinine greater than 2.5, they were randomized to receive terlipressin versus placebo, and the endpoint was reversal of the renal failure, and it worked. So it is likely to come into the market. The word on the street is late summer timeframe that this may get approved. So you may want to learn more about this as you manage patients. This is a Q6-hour IV injection. Better than others, but the limitation is at the top line on the table. Response rate is 29% compared to 16% in the placebo, meaning 70% of our patients with hepatorenal syndrome will still not do well. So this is by no means a cure for hepatorenal syndrome, but a tool for us to use. If you ever struggled with patients who you're sending for tips and worried that the patient may develop hepatic encephalopathy afterwards, do you give prophylactic medicine to prevent encephalopathy? There have been debate about this, and this is a randomized controlled trial where they use rifaximin before they receive tips. And here, I think they used it 2 weeks. They started 2 weeks or 15 days before tips and continued for 6 months. And the curve separated at 6 months significantly. Patients received rifaximin, the blue line on the top, is significantly higher than, better than the green line. So there is evidence that prophylactic rifaximin may be helpful in patients who are going to tips. I don't know how this will work in the real world where rifaximin is hard to get from the insurance standpoint and whatnot, but at least we have some information that if you're really nervous about marginal liver function patients who really need tips, this is something to think about. Some exotic things, but potentially usable growth hormone therapy. We think a lot about frailty in our patients and sarcopenia. There are not good treatment for that. These guys had randomized controlled treatment with a growth hormone, 1 unit a day, rising to 2 units a day. And they show that there's a benefit of using growth hormone in terms of sarcopenia and frailty. The other hormone is GM-CSF. This is a trial from India where they looked at GM-CSF as opposed to norfloxacin in patients who have developed spontaneous bacterial peritonitis. And the hypothesis is that these patients have something wrong with their immune system. So if you can stimulate their immune system, is it as good as prophylactic antibiotics? And they, in this particular study, they seem to show that GM-CSF for a limited duration of time seemed to be better than norfloxacin in preventing SBP. Norfloxacin is not available in this country. The choice for us is ciprofloxacin or Bactrim, which is a bit uncomfortable to use, but that's what the guideline says. G-CSF is the other hormone that Indian investigators have advocated as a treatment of bad decompensation, acute and chronic liver failure. This is sort of a poor man's stem cell therapy. The idea was to use G-CSF, stimulate stem cell generation in the bone marrow, and they'll go into the liver and help regenerate the liver. That was the idea. Indian studies, multiple of them have shown that it is helpful. This is a European study that tried to replicate that and failed. So G-CSF in patients acute liver failure remains an uncertain topic, and we should not try to adopt that in our practice. I think that's all I have for you. I would am happy to entertain any questions. Thank you very much for your attention.